As David started describing your group and what you guys are doing, the more I heard, the more excited I got, because I think what you're doing as a group is very, very unique. And I think this kind of model would readily transplant to other areas around the country. So first of all, what am I going to talk about? There have been many, many drugs used for intravesical chemotherapy. And by and large, I'm going to try and restrict ourselves to the alkylating agents, so mitomycin C and epirubicin. That's predominantly because that's where the best evidence is, and in many cases, the only evidence. One of the unfortunate things is that most of the evidence was done in Europe, and as a consequence, a lot of it is done with a drug that we don't use around here, which is epirubicin. And one of our difficulties is the fact that we presume they're equivalent. There's some evidence to support that they both work, but just bear in mind, we're not necessarily talking apples to apples all the time here. The second is that you can give intravesical chemotherapy in lots of different ways. And in the interest of time, we're not going to go through all the various gyrations that this can be done in. Some of these have been studied, some have not. But today, I'm just going to keep within the immediate, by which I'm defining that as within 24 hours. Probably the best way to get yourself up to speed on this and not have to look through all 30 years worth of data is to start with this. This is a meta-analysis done by Ron Sylvester in Belgium, published in 2004. And it's a pretty good synthesis of essentially everything that happened before 2003, or at least reasonable. So it's a good place to start. What they did is the meta-analysis, they went through the literature and they only looked at randomized trials, and they found, as I recall, 12. And then they looked through those trials and made sure they had methodologic quality, so that started knocking trials out of the list. And then they started looking at several criteria. They wanted primary or recurrent disease. They wanted only TA or T1. They did not want to look at CIS. And they specifically restricted into trials that were randomized between TUR alone versus TUR plus something immediate, typically within 24 hours, although some of the trials actually were within 6 hours specifically. And just by virtue of when they published it, they stopped looking as of January 2003. So anything published after that is not included. And they ended up with 7 trials. They ended up with 1,476 patients, and this is obviously the advantage of a meta-analysis. You can take a whole series of these much smaller trials and try and synthesize all that data together into one. That's its strength. Its weakness is that it's only as good as each link in the chain. So the quality of the trials drives the quality of the meta-analysis. Their median follow-up for the trials in general was 3.4 years. You'll note that basically the range was between 2 and 11 years. So these trials in general all required at least 2 years follow-up, which is one of their strengths actually. So their trials had epirubicin, 2 were mitomycin, and so this is still very relevant to this group. So in other words, this meta-analysis still had over 1,000 patients with using drugs that we can have some reasonable confidence in. It included one with thiotepa and one with pirarubicin, which is analogous to epirubicin. And again, as I said, they're all within 24 hours. So this is one important point to keep in mind. By virtue of the way these trials were set up, and by virtue of the way we tend to think about immediate intravesical chemotherapy, these were, in general, lower risk patients. So 2/3 of them had TA disease. The overwhelming majority were lower grade. By virtue of the fact that these were done earlier in time, they did not have low versus high grade. They were still using the 3-grade system. So probably half of those grade 2s we would currently have said are high grade. It's a little hard to tease out, but in general they were lower grade. Most were primary and most were single tumors. And these are the results. I don't know how many of these these meta-analyses you guys have looked at, but the bottom line is when they looked at the whole thing in aggregate, the difference between TUR alone, the recurrence rate, was 48%. So it's just a crude rate. By virtue of the way they did this, they could not account for time, okay? But just the crude rate published by the trial was 48% versus 37%. So that's an absolute difference of 11 percentage points between the two rates. And thematically, you'll see, this is kind of the way this tends to run. There are several areas where the data is at best weak and more frequently non-existent. One of them is CIS, and that's because almost all these trials intentionally that were just pure TUR versus TUR plus intravesical chemotherapy. There are trials that include all kinds of other things, but ones that just looked at that, as far as I can tell, universally kicked out CIS. So if you had CIS, you were excluded, at least from the analysis anyway. So we essentially have no data whether this is anything in CIS. My prediction would be it wouldn't have any effect, but there's no data to speak to it at all. High-grade T1. This is a little bit hard because more often than not, the trials didn't really separate out high-grade T1s, or even if they had, the numbers would be so small that it would be hard to really speak to any differences even if they did exist. So my interpretation of that is that we really have very little evidence for or against high-grade T1. So I don't think we really even know whether it helps in that instance or not. Perhaps even more telling is the fact that if you get high-grade T1 or CIS, what are you going to do? Well, in this country, odds are you're going to go on to BCG. And there's very little, if any, evidence that an immediate intravesical chemotherapy plus BCG does any better than just BCG. The data is a little conflicted on this. I mean, there's been some things that have said one and some the other, but in aggregate, if you look at it, it's not clear that the addition of an immediate installation of intravesical chemotherapy has any effect on whether BCG is subsequently going to work or not. So if you walk in there and you do your, you're in there doing your cysto and you look at the TUR, and in the back of your brain you're going, you know what, this guy's at the very least going to need BCG. There's no evidence to suggest that adding the intravesical chemotherapy is going to help you in that circumstance. There's virtually zero prospective level 1 evidence to say anything that this helps with progression. So we're purely talking about a recurrence. And so there is a theoretical construct that talks about cost and risk, and if you're just reducing risk, is that recurrence, is that sufficient to be adding chemotherapy to this whole mix? And we can have or not have that discussion. And muscle invasive disease, essentially, were universally excluded in these trials. So again, we have nothing to support using in this. So what do the guidelines say? I've elected to include only 3. There are probably at least 2 or 3 other guidelines out there, but I've included 3 because they're the ones most people recognize. And the first, we're at the AUA, so the AUA guidelines. So what do they say? Now, one thing to just keep in mind is this was in 2007, so some of these trials hadn't been published yet and were not able to be included in this. So this essentially was off of 2 things: the Sylvester meta-analysis, which I just showed you, and they actually did their own internal meta-analysis of mitomycin only, because that's what we use in the United States. So what did they say? Index patient number 1 is somebody who presents with an abnormal growth on the urothelium who has not yet been diagnosed with bladder cancer. And the verbiage is, it is an option to put an initial single dose of intravesical chemotherapy, may be administered immediately postoperatively. And the reason stated for that ambiguity, so 11% over and over again, right? 11% difference, 15% difference, something like that, 40% reduction in risk. Why the ambiguous language? And the reason stated is because you don't have a pathologic diagnosis. That's what's put in the guideline. So, something to think about. So some of it may come down to your own clinical judgment as you look at this thing. You look at this thing and say, this is bladder cancer 99 times out of 100, or this is, what you were referring, this is a little ditzel thing. I'm not quite sure what exactly it is. It might be cancer, maybe not. I'm not really sure. Index patient number 2. A patient with a small volume, low-grade TA bladder cancer. And this was now a recommendation, again, based on pretty reasonable level 1 evidence. An initial single dose of intravesical chemotherapy may be administered immediately postoperatively. They gave a little bit of wiggle room because of some of the issues that we've already brought up. What if you have a deeper section? What if you're worried about perforation, et cetera, et cetera. And their own internal meta-analysis, wasn't presented in the same kind of formal way as the Sylvester study, but they found a remarkably similar reduction in the recurrence rate of about 17%. So that's not remarkably different than the 11 to 15% ranges we've been talking about. How about the high-risk index patients? So there's a series of these higher-risk patients. The AUA guidelines are essentially silent. They neither speak in favor nor against. There's essentially no recommendation whatsoever.
And that's because there was no data for those patients.
That's the way I interpret it, yes, I agree. But just so you know, that's essentially what it says. Nothing.
Well, I was on the panel, and that's why we did it.
Right. So there you go. So if you need all the more finer tuned insights versus what I can get by reading it, you have it right here. All right, the NCCN. Interestingly, just so you guys know, the methodologies of these two guidelines are worlds different. The AUA I would classify as far more rigorous. And will be far more selective in what they will look at and what they won't. The NCCN is done differently. It can respond quicker because it doesn't require the same degree of rigor. On the other hand, it does rely more on sort of a group discussion of what evidence there is. So they all have their ups and their downs. Regardless of any of that, lots of people use these guidelines. In part probably because they can rapidly respond to changes in the literature. So for a clinical TA low-grade lesion, the NCCN guidelines state, and I quote, consider single-dose intravesical chemotherapy within 24 hours. And for everything else, there's no comment made, essentially for similar reasons. The European Association of Urology, and I include this because the Europeans have done a lot of the work here, are a little bit more aggressive about it. Essentially, as you look across their risk strata, so they actually break things out into a low risk, an intermediate risk, and a high risk. And as you look at they essentially recommend one immediate installation across all their risk strata, which is actually interesting because I'm not sure they have the data supported across all of them, but the latest iteration.
Why?
I'm actually not sure I understand entirely, but that's, I looked at the 2011 version just 2 weeks ago, and at least, and maybe I misread it. That's what it seems to say. And then they talk about adding more therapy on top of that, depending on the person's risk group. So they clearly feel that you sort of ought to be giving this a lot more frequently, and then deciding later whether to add in even more stuff on top of that. I'm not sure I agree with that, but so you know that that's there.